Hi, and welcome to February. Welcome to Aging Well. We want to thank you for being here. You know, we always thank our team, Tom Roth, Courtney Hayes, Audrey Belfaro, Abby Archer. But, you know, we put y'all at the top of the list because if you weren't here, we wouldn't have anywhere to go on the second Tuesday of every month. So thank you so much for being here and for inviting us in every month. You know, February is such a fun time. You know, lots going on. Hopefully spring is around the corner, but we are lucky tonight in that we have a delicious dish that's going to be prepared for us by Chef Eric Brownlee. He is with the Katharine Brasserie Bar at the Cardinal Hotel in downtown Winston-Salem. It is an amazing dish. And I'm just tickled to death that we have him graciously sharing his cooking demo with us. So Chef, take it away.
Thank you, Deb. If you don't mind, I'm going to take my mask off. Typically we would keep these on, but for this video I definitely think it'd make more sense if I took it off so you could actually understand what I'm saying. So again, I'm honored to be part of the Aging Well series. This month it's going to be heart health. So I specifically picked out a recipe that is good for heart health. I got some very omega-rich salmon. We got some pomegranate, we got orange. We have a little watercress and arugula. So there's greens, pomegranate, and the salmon. All stuff's going to come together, and it's going to be a really heart-healthy meal that honestly is very approachable and pretty straightforward and simple to make with things you can find at the grocery store. Fairly easy. So we're going to go ahead and get started now. There might be a few tricks I throw in there, and I'm going to try to do this to where it would be the same thing if you went to the grocery store and brought everything home and did it. So obviously you're going to have a cutting board and a knife. Mine tends to slide around here, so I'm going to get a towel and make it damp. That way I can put it underneath this and it won't slide around. I have a damp towel here. I'm just going to lay it on the table. It's not soaking wet or anything, just a little damp. That on there, and then yeah, we're good on that. Got a knife here. So as you saw in the recipe, you went to the grocery store already. You bought some oranges, some sweet potatoes, carrots, watercress, leeks, fennel, and obviously some salmon, some pomegranate seeds, pomegranate juice, syrup. We have living watercress, so it's hydroponic. It's still alive until I cut it off. So it keeps all its nutrients for a very long time, stays fresh. With baby arugula. So the first thing we're going to want to do is prepare our vegetables and potato, because this is going to take a little bit longer than everything else to cook. So we're going to cook this separately first in some water, just kind of like a slow boil, and that way everything cooks evenly on the sheet tray later. So the carrots, we're just going to simply cut them in half. I peeled them already to save time. And I'm going to cook the potatoes and carrots together in the same pot. Normally, if you put these in boiling water, you would want to do them separately because they will cook at different temperatures. But I'm going to start them off in cold water. And since I'll use cold water for both of them, they'll come to the temperature together at the same time, same temperature. So the inside of it will become the same temperature as the outside of it all together. So if I throw this in boiling water, the sweet potatoes would probably get a little mushy on the outside before the inside fully cooked. Same with the carrots. So if I start them in cold water, everything comes up together and they'll be the same through and through. So I'm just going to put all these together in one pot. I'm going to fill up with cold water. Bring it to a boil and let it boil for a few minutes. They should be nice and al dente cooked by then. We'll strain them off and then we'll add them to the sheet tray with all the other ingredients. And then everything will be done at the same time. Okay. While the carrots and potatoes are cooking, I'm going to go ahead and prepare our glaze and the other vegetables. So I have an orange here. I'm going to rinse it off. This next step is optional. and this is the reason I rinse off the orange also. I'm going to take some of the zest off. I'm going to add some to the glaze, and I'm going to garnish the salmon with some also. There's two ways you could do this. I have a zester. If you have a home, very simple to just pull a little zest off the orange. And then the other way is with the microplane. It's becoming more popular, and they're way easier to use than a zester. So I'll do the rest of the orange with the zester. I mean with the microplane, and then see from there. You could also use a peeler if you'd like to, and just peel off a very thin layer of the orange peel, and then dice it with a knife. You don't want to go too deep on the orange. You'll get into the pith of the orange, which is the white part, and that can be very bitter, and it'll give your dish a flavor that you really won't find agreeable. So we're just going to take the very surface of the orange off, and that's the part we're going to use. And you definitely want to zest the orange before you cut it, because it's pretty much impossible to zest it after it's cut in half. So I'm just going to cut it in half and squeeze the juice out. This is a seedless navel orange. So orange juice in the bowl. This pomegranate molasses. You can also use pomegranate juice as well, but it's not as thick, so you might want to mix that with a little honey if you use pomegranate juice. But you could definitely find this in the grocery store and with condiments, or sometimes in the international section. And I'm going to go 50-50. You don't have to measure this. So there's not like a very specific recipe, just half and half. And it's very blended together with a whisk, and that's it. Very easy. We'll go ahead and set that aside. Yeah. Carrots and sweet potatoes have not boiled yet, so we're going to carry on with our fennel. Fennel is a bulb root vegetable. It has a very anise licorice flavor to it, and the bulb is the part we're going for right now. You can garnish with the fennel fronds. You can garnish the salmon with that as well. It has a very nice color and adds a nice little brightness to the flavor. I'm just going to cut the bulb off, and then at this point, it's almost like an onion as far as the I guess the biology of the structure and layout of layers. So we're going to cut it in half, and we'll cut the root off the bottom, and it pops right out. We'll set the side aside, and then we're just going to slice it very thinly. I'm going to come just around it, slice it just like you would an onion at an angle. And then we have a leek, which is part of the onion family. Basically like a giant green onion. It's very mild. The flavor is not nearly as strong or pungent as an onion or scallion. It's almost a little sweeter. So it adds a very nice balance to this dish. I'm going to take the outer layer off. In the summertime, the leeks can be very sandy and gritty, because as they grow and it rains a lot, and the sand will splash up and fall on the inside. So I'm going to do a quick check to make sure that this didn't happen to fall into that category, or else I would rinse it off. But this one looks pretty good. So I'm just going to slice it thinly. And it's mainly the whitish part we want. I have a mixing bowl here. I'm going to add the leeks and fennel to the bowl. A little bit of olive oil, and again, you don't need to measure this. You don't want to drown it in olive oil, but you want just enough to coat it. I'm going to season it with a little kosher salt, and I have a little bit of fresh ground black pepper as well. So we're just going to toss that in the olive oil. And we'll set that aside. We're going to check on our sweet potato and carrots, and they're about to come to a boil. Once they boil, it's only going to take a minute or two until they're done, because again, we started in cold water, so the internal part of the potato and the carrot are going to get hot at the same time. So when that's boiling, the inside of that carrot and potato are also going to be about that same temperature. So while that's happening, we're going to get our sheet tray ready. And it's just a basic sheet tray, like a cookie sheet like you would have at home. I put a piece of parchment paper on top to make cleanup a little easier and so things don't stick. And I also have an aerosol pan spray as well. I'm going to just lightly coat this with, just to ensure that nothing sticks, and cleanup is super easy. And this is just a canola oil. You could get a butter substitute like Pam, anything like that would work. So I'm just going to lightly coat that. And as that happened, the carrots and potatoes have boiled. So I'm going to go ahead and strain these out of the boiling water. And then I'm going to put these in a mixing bowl as well, just like I did with the fennel and leeks. A little bit of olive oil. Kosher salt. A little cracked black pepper. I'm just going to lightly toss those as well so they're evenly coated. And set that aside. So now it's time to, we're going to start our salmon. So I have salmon here that is Atlantic salmon. It's from the Faroe Islands. Any salmon really will work. This is farm raised, but it's raised in a sustainable method. And you can get this at your seafood counter at the grocery store, or you could honestly just use frozen salmon to work as well. Fresh wild salmon would be ideal. I did take the skin off. You could leave the skin on, and the skin on has a tendency to keep it a little juicier, and there will be a little more omega-3s in there as well. I'm going to season that with a little bit of kosher salt and fresh ground black pepper. And I don't need to add any oil to this because there's enough omega-3 fat in there already that you don't need to add any fat to it as well. So I'm going to put this in the oven at 450 degrees. Okay, so it's been about 6 or 7 minutes, and I'm going to pull the salmon out. It's about halfway done, and that'll allow us enough time to let the salmon finish cooking while the rest of our vegetables come up to the right temperature. Okay, it's a good looking salmon right there. It's about medium rare right now, maybe close to medium. So here's our carrots and sweet potatoes that we already slightly blanched in the oil and water. Just kind of spread them around here. And we have our leeks and fennel. Just kind of same thing. Super easy. No specific spot I'm going to put them, just kind of evenly layered so they don't piled up on top of each other too much. And then back in the oven for a few minutes. All right, while that finished cooking, we're going to get our plate ready. So I have some hydroponic watercress here. This is a little more difficult to find than all the other ingredients. You can find at the grocery store a lot, but if not, just add extra arugula. Baby spinach would be a good substitute. A little bit of kale, maybe it might be good. Baby kale would be better. So I'm just going to put a tiny bit on there. And watercress is great. It has like a nice peppery, almost horseradish flavor to it. That I think goes very well with the carrots and sweet potatoes to balance it. And a little bit of baby arugula is also on there. I'm not going to toss this in any oil or salt and pepper or anything like that. The fat from the salmon and the oil that's on the vegetables already will be enough to bring this all together. You could put avocado on at this point as well. That would be really good for the heart, and the richness and creaminess of the avocado would also play very well with the salmon and the greens and the pomegranate and the orange. So you have an avocado laying around and you want a little richness out of this dish, that'd be great. The glaze from the salmon at this point would also make a nice little sauce and it would look good on the plate. So I'm just going to go ahead and drizzle just a little bit around the edge. I have a tiny ladle here, a spoon would work. And that'll just kind of bring all those flavors together a little bit better. And looks good on the plate. We're going to glaze the salmon now and then throw it back in the oven. And this smells really good right now. You start to smell the carrots, the fennel, the arugula in the background. The leeks smell good. I'm going to drizzle some of this orange pomegranate glaze on top of the salmon. And this isn't like a sticky sauce. It's a nice, light, refreshing sauce. Back in the oven it goes. This would be the time when you would want to perhaps pour the glass of red wine. That's good for your heart occasionally. Gather everyone around. This dish is also, if you wanted to make 2 or 3 at the same time, same instructions, maybe get a bigger tray, maybe get 2 trays. It's a very adaptable recipe. All right, I'm pretty excited about this. It looks really good. Okay, I have a spatula here, and I'm just going to kind of gather up all the vegetables. Nothing crazy. Just going to put it on top of the greens. Nice little blend of all the stuff here. And honestly, I have enough here for 2 pieces of salmon. It's a big meal. It's almost a salad with salmon on top at this point. Okay. That purple carrot is begging to be added. A little salmon on top. Some pomegranate arrows here. They call pomegranate seeds arrows. Put a little bit on top. They have a nice little texture and nice tart pungentness to kind of balance out the salmon fat. The orange zest we did earlier, kind of sprinkle that around. Nice little pop of color, and when you bite into it, it's going to be pretty good. And the zest we did earlier, I have the fennel fronds. It makes a very pretty garnish on top. Super easy, super healthy, perfect for spring. I'm going to go eat this right now.
You know, there are many times that when I'm out doing these cooking segments that the chefs graciously invite me to enjoy the entree. And this was one of those times. So I can tell you firsthand, it was absolutely delicious and just the perfect balance of all the flavors. So anyway, thank you again, Chef Eric, for a wonderful cooking demo. Now, when my husband and I, Don and I first moved here, one of the very first places that we were taken is Old Salem. And it is without a doubt one of the coolest, authentic places that we happen to have in our hometown. And one thing though that has recently been open to the public is the seed saving lab over there, where they are harvesting and preserving these heirloom seeds. And so anyway, Katie, and let me just, Inglehop is the director. She is the education coordinator of agriculture and gardening at Old Salem. And she was so kind and is giving us a tour of their seed saving lab. So I want to give you some details at the other end of this video, but for now, let's turn it over to Katie.
Thanks, Deb, and thank you for letting us be a part of Aging Well. So I'm Katie here at the Seed Saving Lab at Old Salem, and just to kind of show you where we start things is we take things that we grow in our gardens, and a lot of times we hang them to dry so that we can harvest the seeds later. And usually when you come in, you come up the stairs, and we have 2 boxes out here. Usually kids really like to get their hands in these, and we usually have okra, and these are the dried seed pods that kids like to open, and adults too. And then we also have beans. that people like to open, and some people can even remember sitting on their grandmother's porches and opening these bean pods. So that's just the beginning of things. If you guys want to come on into the seed saving lab and see what we do. So here we are in the seed saving lab. This is where the work is done. This is where we harvest most of the seeds, and we have lots of seeds that are really important because they're heirloom seeds. And heirloom seeds is just like an heirloom blanket. It's something that's been passed down from generation to generation. And so a lot of these seeds are descendants from plants that were here when the Moravians first set up Salem. And so these seeds can tell us stories about global travel and how things actually came into North Carolina, to the Americas, right? A lot of things have traveled from all over the world to make it into our dinner plates. And so we have things that maybe you might not see in grocery stores because a lot of these things don't stand up to industrialized farming. But if you grew them in your own gardens, they might become your favorite vegetable or favorite fruit. But now you're more likely to see them at a farmer's market, things that are kind of done with more hands-on work and less machinery. But when the Moravians set up Salem, you have to think that they had to really, really work at their gardens. There were family gardens, so if you got married, then the garden in your yard would be your house garden where you would grow things for you to eat, as well as your medicinal garden. So just like you might have a medicine cabinet at your house, they had the herbs and flowers in their gardens that they would use to treat common ailments. So I would let you walk through and you get to touch seeds and ask questions about whatever we have here, because there are things that, again, in seed saving look quite different than what you would necessarily see if you were going to a farmer's market. Like this is the seed for lettuce, which looks quite different than what you would actually see if you were going to a grocery store, right? Most people might not even recognize that as lettuce. And so a lot of things in seed form look a lot different, right? So this is beautiful, but that is an artichoke, right? And a lot of people aren't used to seeing this version of things. We've gotten so disconnected from our foods and growing things that we're not used to seeing these seeds. And that's another reason why this seed lab is so very important, because it really does connect people to what they're eating and what we're growing and where things come from that you do see in grocery stores as well as farmers markets, right? And then also we have these giant gourds. Now gourds might not seem very exciting to a lot of people, but they are very exciting because they tell a great history, right? Gourds have been around for quite a long time in the Americas. So they were first used by Native Americans as storage vessels, right? And all of our squashes kind of came from these, but gourds were an important part of Salem as well because they were also used for utensils, spoons, tools, musical instruments. I mean, you could use this for storing water, storing seeds, but these gourds are actually even more impressive because this particular type of gourd was used to transport seeds across the ocean on ships. They would put the seeds inside and then seal them with wax. And so kind of the thought process behind that was that even if the ships didn't make it, that the seeds would end up somewhere, right? But you know, you have to think this is before Tupperware, before glass containers even, and when they would use, before crockery was really a big part of most people's storage systems, right? Gourds were great at keeping water and seeds safe through the winter, right? And so we also have different kinds of beans, and beans, again, have kind of traversed the earth, right? Most beans come from the Americas. They were a part of a lot of Native American cultures, and still are. And so, but all the settlers took beans and kind of took them back to where they had come from, and then they've been changed a lot. So these beans, and I love these beans actually because they're very waxy and the colors are just fun and the shapes are fun. These beans are very special and they're very rare, and we list these in the Seed Savers Exchange, which is the organization that we're a part of, which is kind of where people trade back and forth heirloom varieties of seeds. And so these are the Dinkelbun bean. So those are just a little fun part of history. All right, and this actually is one of the gourds that they would have used for a ladle or a spoon, right? So we kind of have a variety of gourds to illustrate what multi-purpose things that they really are. And another fun thing that we have is a walking onion. Now these onions are something that came from Pakistan, and they have all these little onion bulbs. And instead of rooting themselves in the ground, like most onions have to be rooted completely in the ground, what these do is these push up a cluster of these that flower and then fall on the ground, and then they just keep doing that and continue to kind of walk their way through your garden. And another fun thing, this is a lot of people's favorite when they come into the seed lab, is this. And so this is a unicorn plant. Now that might not make sense to a lot of people because it has two things instead of one thing. But when it is growing on the plant itself, and this one's a little bit younger, it's closed, and so it just has one thing, right? And some people call this devil claw or cat's claw, because if you were hiking in the desert, this would definitely get stuck to you, right? But this has been used. This is native to the southwestern United States, so this grows in most of Texas, New Mexico, Arizona, and it gets a lovely little flower. The one that we grow here is pink and white. Sort of looks like an orchid, not quite though. But these seed pods, when you eat them, when they're about this big, about 2 inches, they're fresh and they taste kind of like okra mixed with a morel mushroom, right? If you eat them past that time, they just taste bitter. But Native Americans in the southwestern United States have been using this for a really long time to make oil, to make necklaces, to make baskets. They soak these pods in water. So if you've ever seen a Navajo basket that has black woven into it, that is what they use. You may have noticed that I'm not wearing a mask, and we're doing that for the purposes of this video. However, if you do come to visit us at the Seed Lab, I will be wearing a mask, and we require all guests to be wearing a mask right now. So if safety is a concern, it is a concern of ours as well. So a fun fact about poppies is these are the same as the poppies that you would think that would be used for opium. And the Moravians actually dabbled in the opium trade. And they dabbled in a lot of things. They tried to grow tea. They had a lot of camellias brought in to grow tea. They tried to grow opium. They tried to grow silk. They had silkworms imported, and they would eat the mulberries. And so the Moravians kind of did many things in their gardens as a way to make money to keep this town and their homes profitable, right? This was a trades village. This wasn't a farming community, and that's important. Even though farming was a big part of their lives because it was basically how they ate, it wasn't set up the same way as some of the other nearby Moravian towns like Bethabara and Bethania. So another thing that you might really get excited about when you come into the Seed Saving Lab is this wonderful freezer. Now this is what we call our Hollywood freezer, right? Because it does look really nice, especially compared to some of our dry seed storage. And if anybody's familiar with seed saving, there's a time limit on when you can keep your seeds, and they'll still grow things, still be viable. And a lot of times dry storage, that's usually only about 1 year to 5 years, depending on the type of seed that you have. And if things are kept at room temperature, right? Not too hot, not too cold. And always, always, moisture is your enemy because it ruins your seeds, right? So, but in here, we have really extended the shelf life. And things that are kept cold that whole time when you've harvested these seeds and you immediately put them in here, that shelf life can be extended for decades even. We have seeds in here that are 20 plus years old, and we just recently did germination tests, and a lot of those seeds are still growing. They still produce, right? And so we have varieties of things that, again, are heirloom and rare that we want to keep, that we want to make sure that we know if those things are still able to grow. And we want to know if, when we rotate our crops out, that we're planting something that is going to produce another heirloom, right? And so we can talk about, when you come in, all the things that are important when you're growing things, right? Like hybrids, and if things are going to stay true to their parent type or be different, but that's a little bit more sciencey. But you can always get excited about this just because it really does show you how different every variety of thing can look. Like there are so many different types of corn and so many different types of beans and cowpeas. And when it's in this freezer, we get to see not only how things can last, but also how things have changed over time, right? A lot of times you'll see some of the same varieties of things that after a few years, their colors start to change. So it's really a fun thing for people to see when they come into the seed saving lab as a way to kind of understand how important this seed saving work is. All right, and if you guys are welcome to come and see me here at the Seed Saving Lab. Please mention that you saw us on AgingWell, and we are located at 511 South Main Street. And so when you come into the historic district of Salem, we're kind of, we're the second yellow house, and we're upstairs. So I'd love to see you. Thanks for listening.
Thank you, Katie, for such a wonderful tour. As you can see, it's easy to get excited when you learn the history of these seeds and just how rare and special some of them are. And one thing she wanted to make sure I shared with you, they are only open, and I want to look at my notes, from Wednesday to Saturday, 10 to 2. Now, she mentioned that they're upstairs. So if you come in off of Main Street, you have to walk up the stairway to get to the second level, to this kind of balcony areas where you enter it. But if you come around back and enter off Church Street, there are still a couple of steps to get down to from the parking lot to the building, but it's a much easier trek. And also, please be sure and mention that you saw it on AgingWell. She just wants to be able to thank you for coming in and sharing some of her passion. I promise you, you'll get the bug as well. So, February's Heart Month, and we think Valentine's, but the heart is truly the center of our health. And are we doing everything we can to best take care of our hearts? And part of that's our blood pressure. And so we are so lucky tonight that we have got David Reboussin. He is a PhD professor at the Wake Forest School of Medicine. He's going to take us on a kind of a historical trek to let us know, it hadn't been all that long that physicians even knew to track our blood pressure and treat our blood pressure. So I think you're going to find this talk with Dr. Reboussin very interesting. And if you have questions, please put it in the Q&A section below the video. And so I'm going to ask him to join us now and tell us about our blood pressure.
Hi. The thanks, Deb, and thanks to you and AgingWell for inviting me to talk tonight. I'm not a physician, as Deb said. I'm a PhD biostatistician who works on clinical trials. I've done a lot of my work in the area of heart disease, and I've spent a particularly long time looking at the blood pressure. And it's a fascinating story, that I'm looking forward to sharing with you. So the context, heart disease, February is heart disease month. And heart disease is important because it's still the leading cause of death in the US. It has been for a long time. And among the risk factors for heart disease, high blood pressure is one of the most important, if not the most important. That is, a lot of the heart disease that we have is that being caused by high blood pressure, and it's still the leading cause of death in the US. And worldwide, it's tremendously prevalent. There's over 1 billion people, 1 billion with a B, who have high blood pressure in the world. About 70 million people in the US. That's about 1/3 of all adults. And if you look at the proportion of adults who have hypertension in the older ages, it goes even higher, about 75%, or depending on where you draw the line, as much as 90%. A very high proportion of people, if they live long enough, are going to end up with high pressure. So it's a very common problem, and it's really one of the major targets of therapy to reduce heart failure. But it hasn't always been that way, and it's kind of an interesting story that I want to give you some of the the background on. So it was really in the beginning of last century, in the 1900s, when it became easier to measure blood pressure. And they used a device that's very much like the device in your doctor's office now. They put the cuff on, they pump it up, listen to your pulse, they let the air out bit by bit, and they look at the pressure reading, usually in a column of mercury that's off to the side. Devices like that were relatively easy to get, very, very common. And it gave people a way of measuring blood pressure that they didn't have before. So once you can measure it, some people are going to want to measure it. And those people include people that work for health insurance companies. And the health insurance companies showed an early interest in high blood pressure, got a lot of measures of it, kept databases of it, which was hard back then. But that was what they used in order to get better estimates of risk, better estimates of survival and the risk of death, which helped them set the rates for their insurance policies. That was their business. And what they found when they looked at blood pressure is that there was this tremendously large relationship, strong relationship between blood pressure, increasing blood pressure, and higher risk for heart attacks, strokes, and death. And they developed this very quickly in the early decades of the century, so that it was pretty clear. But at that point, they're in the insurance business. They're not looking at prevention and treatment. That really falls to clinical practice in medical science. So it became a question for clinicians, and for clinical researchers, to wonder whether lowering blood pressure would make things better. There was people were not at all sure that that would be the case. That is, if blood pressure may be high, you're measuring, yes, it's associated with heart disease risk, but maybe this is a normal, and there's quite a bit of this, a sort of a normal condition of aging or some kind of compensatory measurement for other things that might be wrong in the body. That is, there could be some other cause for the heart disease, and it's the heart disease that's causing the high blood pressure. So lowering it is not going to help the heart disease. It's just going to give you whatever problems may come from lowering heart disease. So there was kind of this controversy, difference of opinion as to whether it might be helpful or not. And in 1931, there was a physician in Liverpool, England, giving an address to the British Medical Society. And he talked about, there was this common belief that normal blood pressure was your age plus 100. So if you were 40 years old, normal for you would be 140. If you're 60 years old, normal for you would be 160. And he said in 1931, this was undoubtedly incorrect. It was very clear to him, a heart doctor, that high blood pressure really was linked somehow to heart disease. But at the same time, he felt that the biggest danger in high blood pressure was that it would be discovered, because once it was discovered, some fool would try to reduce it for you. So this very seems like a very dissonant point of view. He's very convinced of the association, but not at all convinced that would be a good idea to lower it. And certainly at the time, there was some justification for that kind of thinking, in part because they didn't really have any good treatments. The kind of treatments that had been explored for lowering blood pressure were things like injections of mercury, injections of iodine. They would expose patients to malaria in order to induce fevers, because they knew that people with high fevers often experienced a decrease in their blood pressure. So those are not the kind of long-term therapies you want to be using for treatment of a chronic disease. So they had these things that they had been experimenting with, but they didn't really have, they really didn't have a good way to actually manipulate blood pressure, certainly in a safe way. And it was, those things were reserved for very special cases. So for decades after that, through the middle of the century and into the 60s, this kind of controversy over whether or not it would be important to reduce high blood pressure continued. And in some ways it was prolonged because they still weren't able to develop a lot of therapies for it. In the 50s, the rice diet became kind of the preferred method, but the rice diet, very inconvenient, it's difficult to say. Again, not a long-term therapy. Yes, it was able to lower the blood pressure a little bit, but not very effectively and not for a very long time. But there was also research going on looking at different types of drugs, different types of drugs that might be discovered, or existing drugs that might be useful in lowering blood pressure. And in the early 60s, they finally came up with something. It's now called a diuretic drug. Something that was very effective at lowering blood pressure and had relatively few side effects compared to the other kind of treatments that were available, and was convenient for long-term use. So we finally had a situation in the 60s, where there was this constant, very open question as to whether lowering blood pressure was going to be good for your heart, or not. And finally, they had a treatment that would let them manipulate the blood pressure and find out. So the stage was set. There were a number of smaller randomized trials, clinical trials done, but in part because of the way they were done, because they were small, the results were somewhat ambiguous. And it was really the Veterans Administration that took the bull by the horns and decided that they were going to come up with a definitive answer for this one way or the other. They obviously have a network of VA hospitals all around the country treating veterans. So that's access to a very large population, a population that was older, a population that had a lot of heart disease. So they did a trial where people that were in the trial were randomly assigned either to be treated normally or under usual care for blood pressure, which was not very much rest and things like that, avoid stress, versus getting a pill that would actually lower your blood pressure significantly. And what they found and announced in about 1967 was that it was a tremendous benefit. It was a huge reduction in the number of heart attacks and strokes that the people in their study were having. Now, all the people in their study were men, by the way. These were large studies. It was definitive, changed clinical practice, all based on men. Obviously, that's what the VA had available. But it sheds a little light on the lack of emphasis on diversity and inclusion for medical studies in those days. It took a long time for things to change, but they're getting better now. So with that development, it stimulated a lot of additional research. Those results were replicated. It was various implications for clinical practice were explored. And in about 1977, there was the first blood pressure treatment guideline in the US, and it recommended a target of 160/95. I know your blood pressure is measured with these two measurements. The larger number and the smaller number is technically called the systolic and the diastolic. These are the 2 points when your doctor is listening to your pulse, where the pulse changes as the pressure in the cuff decreases. So more than that, it's probably not too important to know, but you do have two numbers, and the first guideline was 160/95. Now, normal is usually considered to be something like 120/80. Some opinions vary on that point. So yes, they were reducing blood pressure, but the people in their study had very high blood pressures, 180, 190, things that would be very alarming today. But they had done a lot by getting it down to 160, but they were nowhere near normal. This spurred, a series of large, again, very carefully controlled clinical trials, a lot of them done by the National Institutes of Health through the 80s and the 90s, into the 2000s, where treatment was refined, protocols were defined, different types of drugs were tested, and a lot of real progress was made. And just in terms of the kind of impact this had, in about 1940, the 5-year survival for people with what was called malignant hypertension, that is very high numbers that did not reduce with avoiding stress and things like that, or increasing exercise, high numbers that wouldn't come down. So this malignant hypertension, 1940, 5-year survival was 1%. So extremely low. It was a very dim prognosis. By 1986, right about 35 years later, the survival had gone up to 75%. And by 2000, it had gone up to 90%. So there's this really tremendous benefit of lowering blood pressure is having on heart attacks and strokes. Reducing and preventing deaths from cardiovascular causes. And this was around the time where they started this public health campaign. Hypertension or high blood pressure was called the silent killer. That is, you don't feel any different. You don't know. Your people with high blood pressure feel more or less normal, and yet it's putting them at very high risk for hypertension. The others, know your numbers. That is, your doctor is taking your blood pressure. Listen to what he says. See if you can remember what they are. Pay attention to the guidelines. And over time, over that period, the guideline did get reduced further. From about 160 to 140. So again, sort of a step closer to normal there, about halfway. But there things kind of stalled for a while. There was not a lot of enthusiasm for targets below 140. The evidence there was very weak. People were a little reluctant to conduct an experiment like that, particularly with older patients. Now, there had been a number of trials that were focused on older populations, and did find some benefit. But again, they weren't as large. They weren't as clear. Some of the safety issues were not clear in those trials. And generally speaking, the feeling that that it was really important to treat older populations was not widely accepted. So into that situation in sort of the late 2000s, and starting in about 2010, another trial was fielded called the Systolic Blood Pressure Intervention Trial, or SPRINT, which decided to address, like the VA studies had done back in the 60s, the question of, is lower better? Is blood pressures are lower now, but is lower better? Would more lowering be good? I was lucky enough to be involved in that study as part of the leadership team. So I heard a lot of talk. Everybody else, was physicians and clinicians, some of whom had been treating blood pressure for a long time, and there was really no consensus about about whether or not the trial was going to be positive or not. It was an open question. People could disagree. Honestly, about their opinions about what would happen. So it was clearly important to test, clearly a lot of controversy. And SPRINT made some good choices, knowing that this was a controversial topic and that it was going to attract a lot of attention one way or the other, whether the blood pressure lowering was good or bad. That everything had to be very carefully considered. Everything had to be data collection and had to be of high quality, a lot of attention to validity. And they also made a couple of other good decisions. For one thing, there was no upper age limit for the recruitment. A lot of trials, blood pressure trials, many of them, not all of them, were excluding people above 75 or 80. So that really a lot of the results that were in the literature couldn't be reliably extended to older populations. So SPRINT had no restrictions like that. And we had people randomized in the study that was, that in their 90s. I believe we had somebody who was 100 years old. So really great expansion. One of the only trials that had that large an age range in this field. The other decision they made was to look at cognition. That is, do cognitive assessments and look for cognitive decline in this population. And this is often had been done in other studies as sort of a sub-study or part of the study, part of the a subgroup of the participants might get it. It was done in everybody in SPRINT. SPRINT was about 9,000 people, so a really large cohort that's getting that has a very broad age range. Getting this intensive blood pressure lowering, to much more than the current target. And looking, not only at heart disease but also at changes in cognition, effects on the brain, and no certainty about how it was going to come out. Well, the end of the story was that just a couple of years in, before we were, several years before we were planning to end the trial, it was stopped. There was a monitoring board looking at the results and came to the decision that the question had been answered, and there was unexpectedly large positive results. And this was positive results not just for heart disease, that is, heart attacks, strokes, heart failure, other deaths from cardiovascular causes were reduced by 25% in the SPRINT study. It also had an effect on total mortality, that is, all-cause death, even from causes that were not apparently related to the heart. Those death rates were decreased by almost 30%. So two, very large reductions. You remember we were talking about we've already, increased the 5-year survival, from 1% to 90%. How much further can you go? Certainly getting to 100% seems pretty ambitious, but this was really a big step in that direction. So the study was stopped early. There was a lot of publicity, a lot of fanfare about it. And as you can imagine, the people that were dead set and convinced that it was not going to work right thought that there had to be something wrong. And there was a lot of controversy in the literature. Sprint, again, you did the right thing by making the data publicly available early on. That is, anybody that wanted to have a look at the data, could do it. Make sure that we had analyzed it right. Make sure that we hadn't left anything out, or if there was a better way to do it. It was really this is really, there's been so many publications on the distributed data, not even from the investigators, who have also done quite a lot of good work, of course. So with this kind of transparency, there's been a study that replicated the result, and we're getting to the point now where the results are more and more accepted. There's one continent in the world that I don't want to mention, but it's Europe, where they've been especially reluctant to accept this result. And I think we're probably going to have to wait until they do their own trials and see it for themselves, at least in some of the countries there. So the question's been answered to the satisfaction of most practitioners. The lower is better. We have the evidence to show that now. And this was manifested in another change to the guidelines, where the guidelines were reduced again. The current guideline now in the US and in a lot of other countries around the world is 130 over 80. So all that's great. We have great evidence. We had a great trial that was able to build on decades and decades of work. All moving slowly towards the same goal. But the challenge that we have now is to change clinical practice. That is, we have a guideline, we have evidence, but what really matters is what physicians, what your doctor, what doctors all around the country are doing, deciding what to do when they're confronted with a patient that has high blood pressure. And the part of it is just getting the word out, letting them know that the evidence is here. One of the important developments that happened after the end of the trial, because we hadn't had enough time to observe the cognitive decline, we continued to follow the cohort for a while. We're still doing it. And what we found was that in the group that had the lower blood pressure target, there was actually a 15% reduction in mild cognitive impairment and dementia. Mild cognitive impairment is like a stage that people go through on their way to getting dementia. That was reduced by about 15%, not as big as the effects on heart disease, but there's no other intervention in all the years that we've been studying Alzheimer's that's been shown to reduce clinical cases of cognitive impairment and dementia. So it's an important difference. There's a lot of controversy around that result, as well as you can imagine. The evidence is not quite as strong, but we're continuing to follow. But I think the evidence is good enough that it should give you one more reason, if you've got heart disease, to think hard about whether this might not be good for you. So I think if someone has high blood pressure, or you have high blood pressure, you're talking to your doctor. If you know that your blood pressure is above the guideline, if it's above 130 or above 140, I think it makes sense, regardless of your age, to talk to your doctor, and just ask. Not every physician, not every treating physician agrees with the evidence. And again, these are conscientious, honest people having disagreements. It's still possible to have disagreements like that these days. And your doctor may not agree. Your doctor may know something special about your particular case that makes him or her think differently about what your course of treatment. That's fine. That's good. But it's worth having it's worth having the conversation. It really can improve your health. It can potentially reduce your risk of heart attacks and strokes, and possibly be also good for your brain. And so I think the ongoing work now is really to get the word out, help get people to think about it, and get people to talk to their doctors. So thanks for listening. It's a lot of story in a short period of time.
Well, and we already have some questions rolling in. So I hope that you're ready to jump on a few. I have a couple here. So are there any things I can do to help control my blood pressure, such as maybe exercise or physical activity?
Sure. It's a lot of evidence, and I've also been involved in some work that was looking at the effects of weight loss, for example, on heart disease, and it's generally true that those kind of things, lifestyle changes, can reduce your blood pressure. Salt intake is a major factor. And if you look at the magnitude of the effect of these things, it's positive. It does lower your blood pressure. For the most part, though, one pill will do a lot, and a lot of it's sort of equivalent to a lot of lifestyle changes. More often, I think it's gets used in treatment to sort of postpone having to go on blood pressure medication. So, you don't mind telling my own story. My blood pressure has been a little high. I was in the study working on the evidence. I had to say to my doctor, are we going to have to do something about this? And I was, so I got the recommendation to lose some weight. I did that. I got the recommendation to exercise more. I did that. And those things helped. But eventually, I'm at the point now where it's I still do those things. I maintain my weight. I exercise every day, but I also need the help of a medication. It can keep you on less medication in the long run. People that have severe hypertension sometimes end up on 2 or 3 medications that could start to be burdensome. So yes, it's helpful. You may need that, may be enough, and if it is, great. But if you need more, you don't hesitate to use the drugs as well.
Well, understanding you're not a clinician, if some of these questions fall out of your expertise, I think the best advice is just to encourage people to see their doctors and it maybe ask these questions. So you may or may not know these, but so when is the best time to take blood pressure medication? In the morning when you get up, or before bed at night?
So I'm going to take the not a clinician defense on this, but I think I've had some of these conversations, and I think the question is really what's easiest for you. Now, your doctor may have an opinion. If your doctor has an opinion, I advise you to do what your doctor says. But if your doctor doesn't have an opinion, what usually tends to be the problem in the long run with these kinds of medications is it's adherence. It's people not taking them because they don't like them for some reason, or forgetting to take them. So I mean, what's most important is to take them consistently, I think, and again, confirm that with your doctor. But that's probably the deciding factor in most cases.
Well, I'm going to combine 2 questions into one because it's kind of both ends of the question. What are the symptoms if your blood pressure is too high? And at what level is your blood pressure too low?
The scary thing about high blood pressure, this is the silent killer campaign, is it can be quite high, and you wouldn't know. If it's been very, very high, like up in the 200s, President Roosevelt had a blood pressure that was that high near the end of his life. You're really not necessarily aware of it until it starts causing other problems. It could cause problems with your kidneys, for example. So to know if your blood pressure is high, you have to get it measured. Ideally, it would be your doctor that did that for you, but there's other ways to get blood pressure measurements. You can get a home measurement device to find that out. You won't necessarily feel any different, if your blood pressure is high. And then how low is too low? So the SPRINT study was trying to treat people down to 120. But we didn't treat people down to 120 whether they, if they couldn't tolerate it. The idea was to treat it as low as you could. but without going to the point where it was causing difficulty. So, I mean, when is it too low? It's too low when you start having side effects of the medications or other problems related to your therapy. And there's no evidence suggesting that going lower than 120, if you can get there, is better. That's the sort of study that may have to be done in the future.
Okay. And this one, I'm guessing you're going to defer to this person's doctor, but what is the best medication for controlling blood pressure?
Absolutely. Yes. So absolutely, it's best to have that conversation with your doctor. There's about 5 or 6 different types of medications, and there's several different, pharmaceutical companies making different versions, within each type. Some types are not appropriate depending on your medical condition. Again, I'm not going to start diagnosing things here. So some are counterindicated. Some are better if you have certain conditions. It's a conversation you have to have with your doctor. In my case, I'm relatively uncomplicated. I was able to get get a diuretic, which is one of the oldest. Least sophisticated ones, but for me, it works just fine. It's not necessarily the best one for everyone, though.
Are there any, and I'm always appreciative of people's time. We always try to end at 6:30, but we have so many good questions coming in that our guest has agreed to stay and keep answering questions. But if y'all need to leave, if you've got other appointments, it won't hurt our feelings. But while we have the expert, we want to take advantage and get your questions answered. Okay, are there any negative long-term effects from blood pressure that is too low or lower than the ideal?
If your blood pressure is too low, that is, I mean, again, we don't want to treat the blood pressure to be super low. Certainly, you don't want to go, based on the evidence in the current guidelines, you would not want to lower it. On the current guidelines, you would not want to lower it below 130. Now, people that were in the SPRINT study went a little lower than that, but they were part of a carefully controlled study. They were seeing the study staff every 3 months. They were getting constant monitoring. That's not realistic in clinical practice. I mean, it was important to do it that way so that we could answer the question. But the guidelines for clinical practice are really more at 130. So I wouldn't necessarily pressure my doctor to lower it below that. The sort of things that can happen, you can get, hypertension means too high. Hypotension is the opposite, too low. If you don't get enough, if you're not getting enough blood to your head, you can be dizzy. You can have falls. One of the big concerns about lowering blood pressure, for the clinical trial, was that there would be a lot of these cases, particularly in older people. Now, what we actually found was those tended to be a little less common in the people that were getting their blood pressure measured more, that is, getting it under better control. And we don't exactly know why. That was a little unexpected, but it was a clear result. And it seems to be that at higher blood pressures that are less well controlled, you get bigger swings. So that being a little lower might actually not be bad for preventing these kind of episodes of very low blood pressure that might cause dizziness, for example.
What is the impact of alcohol on blood pressure? I'm
sorry to say that it's not good. There's a sense, I think we heard during the salmon presentation, which I'm still thinking about. The idea you would add a glass of red wine to that, for the purposes of improving the effects on your heart. And it may have some effects in the area of for atherosclerotic disease. That is a different type, not blood pressure. Alcohol tends to raise blood pressure a little bit. I think there's no reason to stop drinking alcohol altogether. But again, follow your doctor's recommendations for your alcohol intake. If you want to lower your blood pressure a little bit and you're having a substantial amount of alcohol during the week, try reducing it a little bit. That will probably have an effect on your blood pressure, making it a little lower.
So I have a follow-up to that. Is there a difference in wine versus like hard alcohol or corn alcohol? I think it's called distilled.
The evidence here is not real clear.
Okay.
And one of the reasons is it's hard to do a study where you're sort of randomizing people to you have an increased intake of alcohol. This is very unpopular, in some settings. So there's a theory for the red wine that it's not the alcohol itself, but it's a component of the grapes. It's the grape skins, for example, that may be having the positive effect. But even there, the evidence is not too clear. So I don't think that's a question we can answer. I'm sure that moderate intake, no more than moderate intake is what your doctor would recommend. I think that's probably good advice.
Okay. Do I understand there are new drugs that are non-statins?
So statin is a drug that you take for lowering your cholesterol. They don't have any effect on your blood pressure.
Okay.
Something like the kind of names that that you hear for blood pressure drugs are like the diuretics that I mentioned, ACE inhibitors, ACE and ARB inhibitors are pretty common. Calcium channel blockers is one you hear sometimes. If you've had a heart attack, you might be on a beta blocker. So these are all technical names of classes of drugs. I think that a statin would not be used for this purpose. But I believe there are other drugs that are available now to treat high cholesterol, which is of course also a major risk factor for heart disease. But I'm not as familiar with those.
Okay. What are the side effects of these medications?
So for the side effects for the blood pressure lowering, as I said before, this was really one of the major concerns about the SPRINT study from the people that thought that either it wouldn't work or it would reduce heart disease, but it would also increase these kind of adverse effects. And the kind of effects are particularly in the older population. What we found was that actually the frequency of the sort of collection of events or safety issues that came up in the high group, in the group that was not as intensely treated, and then the lower group were about the same. Those numbers were almost exactly identical. Particularly in the people over 75, they were right on top of each other. And as I said, the biggest concern among those, I think, was probably falls, dizziness, and falls, which is can be very serious, and you have some long-term consequences. They were actually reduced a little bit in the lower group. Now, the sort of things that were increased were what they call electrolyte imbalances. When you get blood work done at the doctor, they're going to look at your sodium level and at your potassium level. Sometimes some of the drugs will throw off those electrolyte levels, and that has to be watched. But that's something that your doctor takes care of. Again, if that was true, you wouldn't know it. The other sort of short-term effects on the kidney, there was more episodes of kind of short-term kidney problems, and all of which resolved in a short period of time with treatment. So the side effects in the trial were really pretty mild. Now, a lot of the controversy and a lot of the pushback on the results of the SPRINT study, was centered on side effects. But I think a fair reading of the whole picture is that there was not a lot of increased risk of safety events from the blood pressure lowering.
And I think our last question for tonight, well, actually, no, one more just came in. Can you share any findings, background, or perspectives about clinical trials on high blood pressure, specifically among African Americans who may disproportionately suffer from diabetes, heart disease, and high blood pressure?
Yeah, absolutely. That's a great question. I mean, there's at least one study that was focused entirely on blood pressure in African Americans. That was the ASK study, the A with 2 A's. You're looking at a specific. I'm not too familiar with that study. Looking specifically at one medication, which they had reason to believe might be more effective in African Americans. I don't think that turned out to be true, but there's certainly some attention in focusing treatment options if not specifically for African Americans, at least something that's going to work as well for African Americans as it does for anyone else. And I mentioned earlier, for the VA trial, it was all men. We did a pretty good job over the course of time, including women more equally in these trials, and that's still true. In the Sprint trial, we had a target for inclusion of African Americans and other race ethnic groups, which we hit. It was not 50%, it was more like 25%. That's actually pretty good for trials of this type, just in terms of the patient population that's available to recruit from. And we found no difference between African Americans and the rest of the cohort. That is, the benefits appear to be about the same in both groups. Now, we don't have it's not as well balanced on that as it might be, but the evidence we have suggests that it works as well there. And then more broadly in clinical trials, it's really a different time. There's far more emphasis now on making sure that recruitment is fair and you conduct it in a way that the results can be extracted to the whole population, not just a very narrowly defined one. And there's, I think the good news is that practice is changing. I think the practice of clinical trials is changing. And I think over the long run, what we hope is that will sort of build faith and confidence in that this type of research is doing the right thing and producing results that everybody can believe in.
And one last, this may be something you defer to a physician, but what is the current thinking about taking a baby aspirin as a prevention of heart attack or stroke?
It's still an open question. There was a lot of work early on that suggested that was a good idea, and that had some benefit. Thinking changed a little bit. Basically the needle has gone back and forth on that. The most recent thing I've seen, and again, this is not an area of that I follow as closely as I do some other areas. It was the results of a study that were not very conclusive about it. And I think there's some open questions there, and possibly some red flags. And again, the person I would count on to give you good advice on that question is your own doctor, who knows your situation very well. And I'm always impressed, when I talk to my doctor and other doctors, and how well they know the literature that's relevant to the people that they take care of. They're really a great bunch. So I would have that conversation with your doctor and see what the opinion is there.
Well, and kind of selfishly, if people around here are, especially Wake Forest patients, they've got access to the most cutting edge research findings. So I'm with you. I get excited when I go see my doctor and she tells me about the latest updates in my care. So I love that. Well, guys, we are over time. Thank you, Dr. Reboussin. Thank you so much for hanging in there with us and answering all these questions. I want to date with y'all again next month. How about March 8th? And we're going to hear from Christina Hugenschmidt. She is going to be talking about caring for the caregiver. Y'all know that Dr. Smart retired. And so at Ed Shaw, I don't know where, I just went somewhere else in my memory, but Dr. Ed Shaw retired, and it's Dr. Christina Hugenschmidt that is now over the memory counseling program. And so she is going to be sharing information with us about caring for the caregiver. So please, please, please mark it on your calendar. Be here next month, March 8th, and we'll see you again. So until then, be safe.